Get started so we can finish on time. I just want to remind all of the invitees to the GlaxoSmithKline luncheon at 12 o'clock that your luncheon will take place a half an hour before this session completes, and it will be in the Aberdeen room, which is directly across from here. Again, the GSK luncheon on ITP is directly across from our main auditorium, and it will be starting a half an hour before our plenary session finishes. This session is on Hodgkin's disease, and I'm sharing the chairmanship here with Professor Gogoi, who is the head of the Department of Hematology at Gauhati Medical College in Assam, India. Welcome. Thank you. I'm going to talk to you folks today about Hodgkin's lymphoma, the latest concepts. And my thrust here is to give you some material that you can use in your clinic right now, that you, I hope, will find this information useful. I will be talking about some products that are just coming to market in the United States, or just have come to the market in the United States that may not be available here, but hopefully will be available to you shortly. And I hope this information will be useful to you in caring for your patients. Now, the main intent now in Hodgkin's clinical research is to have less toxicity, because we cure at least 85% of our Hodgkin's patients. So we want to know is how to cure these patients with the least impact on them. And to start, we need to figure out what role does PET scans play in this effort. In other words, you've heard throughout these sessions about INTERIM PET scans, and they remain very controversial. And the question is, can they be of any use in helping us plan our therapy for these patients? What we have done in an international study, Dr. Hutchings, Dr. Kostagoglu, and myself, have looked at PET scans after one cycle of therapy, that's 2 treatments of ABVD, versus the traditional 2 cycles or 4 treatments of therapy, looking at the value of PET scans in this situation. We had 4 participating nations: Denmark, the United States, Italy, Poland, and approximately 20 participating institutions. Now, the patients we looked at were of all stages. We did not just pick out patients who had good prognosis or limited stage. And as you can see, disseminated disease, if you consider disseminated disease stage 3 and stage 4 disease, almost comprised half of the patients. Over half of them had B symptoms. So we did not select out just patients with limited disease. When we looked at a comparison between PET1 and PET2, that is a PET scan after 1 cycle of therapy versus a PET scan after 2, we found that the negative predictive value of a PET1 PET scan was 98%. In other words, only 2% of patients who had a negative PET scan after 1 cycle, and this included almost half of disseminated disease, relapsed when they had a negative scan. So just 2% of patients relapsed, meaning, frankly, that if you get a negative PET scan, your chances of relapsing and your need for subsequent studies is probably very minimal. On the other hand, if you got a positive PET scan after 1 cycle, our predictive value was only 63% versus 85%. So it's better to tell in terms of how a patient's going to do with the second cycle if the PET scan is positive. So we had some false positive results, and I'd like to emphasize that every positive PET scan, before you act on it, should probably be confirmed with a biopsy. The other point that I want to make is with regard to concordance. If you're going to use PET scans, and they're extremely useful, it's important to have someone who really knows how to use the PET scan. We had nothing but pros that are professionals who were really looking at our PET scans, who do this for a living and are really very much concerned with PET scans. And our concordance rate was well over 90%, indicating that you really need somebody good who knows what he's looking at. Now, having put that in context, the first study I want to tell you about, which was presented as an abstract 547 to the American Society of Hematology, was a rapid trial in patients with clinical stage 1A and 2A Hodgkin's lymphoma who had a negative PET scan after 3 cycles of therapy. And this is a study from England, where they gave 3 cycles of ABVD. If the patient was a non-responder, they took him off the study. If he was a complete responder or a partial responder, with the PET scan. What they did thereafter is if they were positive, they gave a fourth cycle of ABVD, remind you this is limited disease and radiation, or if you were negative, they would randomize you between involved field radiation and no further therapy. So those PET negatives, after 3 cycles, not 1 or 2, but 3 cycles, if you were negative, you were randomized between involved field radiation and no further treatment. And what they found was that while the PET negative patients had a higher number of patients with progression, that the death rate for those patients who got involved field radiotherapy was higher, so that the progression-free survival and the overall survival was no different. So you did get a little bit better disease control in approximately maybe 6% or 3% of patients, but that was not enough to make any difference. And when you look at the toxicity, the involved field radiotherapy arm had a great deal more toxicity than those patients who got no further therapy. So in summary, they looked at 602 patients. 75% of the patients were PET negative. And in this randomized study, those PET negative population, the 3-year progression-free survival was 94%, and the no further therapy was 91%, a difference roughly of about 3%. So the risk difference was 3%, and this was within the maximum allowable differences, according to their statistics, of 7%. So in conclusion, what I can say to you that patients who have a low-stage disease with a negative PET scan after 3 cycles of ABVD have an excellent prognosis. No further therapy is really needed, and these patients can avoid radiotherapy. And I hope this is something that you can use in your practice today. Now, I want to point out that these data are similar to those reported from Argentina a number of years ago at the American Society of Hematology for all stages of disease, not just limited stage. They did it after 3 cycles, and they got the same sort of results. I also adduced that with the slightly higher rate of false negative PET scans after cycle 3 in these patients, could we have avoided that had we done the PET scan after cycle 2, or even better yet, cycle 1? So response-adapted therapy based on quality-controlled, assured PET scan imaging, people who really know what they're doing, may become the future standard of care in early-stage Hodgkin's disease. Now we'll take this one step further. There was another abstract reported from Canada where they did an individual patient data comparison of the German Hodgkin study group HD10 and HD11, which used combined modality and limited numbers of ABVD, versus the National Cancer Institute of Canada's clinical trial where they used ABVD alone. Again, looking at chemotherapy alone versus combined modality. Now, this is how the Germans stage their patients who have early stage disease into favorable and unfavorable. I won't go into all of it, but if you have what looks like limited disease and you have a large mediastinal mass, extranodal involvement, a high SED rate, or 3 or more involved lymph node areas, they consider you to be at high risk, which is different from the way the Canadians did it. This is a very busy slide, but what the Canadians essentially did is they took out the very best prognosis patients. Those are the ones with 1 lymph node and no symptoms, and then what they consider their high-risk patients, which were basically patients with bulky disease. And so here's a comparison of how they treated their patients. If you were early favorable in the Germans, you would get 2 ABVD plus 20 gray of involved field radiation. If you had unfavorable limited disease, you got 4 of ABVD and 3,000 gray of involved field radiation, which is different from the National Cancer Institute of Canada, where they gave you 4 to 6 cycles of ABVD, depending on your response on the PET scan. So what they did is they took all the patients, and the Germans were very cooperative and sent them the data that fit the categories of both of these studies, the Canadian studies and the Canadian study and the German studies, where they had the same patient population. And what they found is that the patients who got the radiation and got the German way of treatment had more toxicity. On the other hand, they got a little bit better control in terms of time to progression. If you'll see here, there's about a 6% difference. Most of that is lost because of the enhanced toxicity. And so what you end up with is an 8-year overall survival of 95% in both arms. So again, chemotherapy alone, 4 cycles, did as well as giving 2 or 3 cycles of chemotherapy plus radiation. So if you want to avoid radiation, you can do so by simply using your PET scan and your chemotherapy alone. So what we can say in summary is that combined modality therapy improves disease control by about 4 to 7%, but superior long-term overall survival of combined modality therapy is highly unlikely. So what you do is you select your patient using your PET scan, and it seems very unlikely that if these studies are followed longer that you're going to see very much difference in the overall survival between the two approaches. Now, what's new for relapsing and refractory disease? And what I'm going to be talking to you about is the use of brentuximab vedotin. Again, you've seen this slide many times. What this is an antibody to CD38, which is seen both on Hodgkin's disease as well as anaplastic large cell lymphoma. What you have is a toxin attached to it, which gets incorporated into the cell, and it kills the cell by interrupting the microtubule network. Now, the overall survival after treatment with vedotin in patients who had really what we call very bad disease, these were all relapse or refractory patients. These patients also, I might add, had failed autologous transplant. But if you look at all patients, the median observation time from the first dose was about 29 months, and 59% of these people remain alive with the median overall survival not having been reached. So this is really some really very good preliminary data. We've now done long-term studies on this, and what we find out is that at 24 months, if you get a really good reaction to this monoclonal antibody with the toxin, that is, if you had a complete remission with this product, that you had a 91% chance of being alive at 24 months, which is extraordinary because these are patients who really didn't have a whole lot more that could be offered them, since I said that many of these patients had already been transplanted. Again, what was key was if you had a negative PET scan after 4 cycles of therapy. You clearly did very, very well. You can look at these data of patients who were alive at the time of up to 3 years. So in conclusion, after a median observation time of 2.5 years from first brentuximab vedotin, 60 of 102 patients, 59%, remain alive at the last follow-up, and the median overall survival has not yet been reached. And what's very important is that if you achieve a negative PET scan, and it didn't matter when you relapsed, whether you had a short progression or a long progression, this medicine really works for these patients. So what we're saying is this medicine overrides inherent drug resistance, which is not so easy to override by using high doses of chemotherapy. Autologous transplant in patients who have truly refractory disease still doesn't work very well, as I'm sure the people from the MD Anderson, Dr. Champlin, will also concur. I hope.
I agree.
He agrees. Okay. Now, what they did do in Abstract 3701 is they looked at the survival benefit of patients with relapsed Hodgkin's disease who got this product after autologous transplant. And what they did is they did a retrospective analysis of how patients fared after auto transplant in the past. And again, this is retrospective, and you always have to be very careful in interpreting disease data, how they did in comparison. So they did this comparison, and lo and behold, those patients who got this product, and I'll guarantee you that all the auto transplants in the United States are going to take note of this, that this product seems to enhance the responses and the overall survival of patients who underwent autologous transplant. Now, I might add that now a randomized study, a prospective randomized study is being done. So now what are we doing for advanced stage Hodgkin's disease? Can we improve the cure rate and reduce the toxicity from advanced stage disease? And this was a study, again, using the same product and using either ABVD or AVD in newly diagnosed advanced stage Hodgkin's disease. And essentially what they did is they gave the product as they gave the ABVD. And what they found out is that they got really fantastic responses. In those patients who had ABVD, they had 100% of patients when they did the PET scan at cycle 2, and 92% of the patients who got AVD without the bleomycin were all in complete remission. Now, one of the problems that they ran into is that this product seems to enhance bleomycin toxicity. And of course, as you know, bleomycin toxicity is very capricious, that it can come on at any time. And it seems as though this product may make it worse. So what they've done is they've looked at ABVD versus AVD using these products, and what they find is that they're getting response rates of 95%. Again, these numbers are very, very small, but these numbers look as good as if these patients had limited stage disease. So it may turn out one day that we don't really need to worry so much about relapse rates in these patients with disseminated disease if we give them this product. So the recommended regimen is 1.2 milligrams per kg of brentuximab vedotin every 2 weeks combined with AVD, not ABVD. So we've done away with the possibility of bleomycin toxicity. And it appears to be well tolerated and manageable. And as I said before, we don't like to use bleomycin with this particular product. So a CR rate of 96% observed at the end of frontline therapy with brentuximab vedotin combined with AVD looks as good as anything you could possibly want to get. Well, we'll have to wait and see. We've got controlled randomized studies again being done with this. Now, the other study that I want to talk about is BEACOPP versus ABVD. As you know, the Germans and the Europeans, to a large degree, use BEACOPP. We in the United States don't like it because we think that it's too toxic. The Europeans say, yep, it may be too toxic, but we cure more people with it. So this was an intergroup study led by the EORTC lymphoma group in Europe, of course. And what they did is they looked at ABVD, standard ABVD, well, they're giving 8 cycles, that's a little more than we generally give, versus BEACOPP. First 4 doses of escalated BEACOPP and then 4 doses of, quotes, regular BEACOPP, as the Germans would normally use as a standard therapy. And what they did find out is that in terms of progression-free survival, BEACOPP is better than ABVD. However, the toxicity was fairly formidable with BEACOPP. So that when you look at event-free survival, there isn't a whole lot of difference. And of course, when you look at overall survival, there's no difference. So as they were just talking in the previous session about toxicity versus relapse, in terms of graft versus host versus no graft versus host, you've got the same thing here. Do you want to give a lot more treatment to get just a small difference in your progression-free survival and no impact on your overall survival? I would deduce that the answer is no, that if we use PET scans, or if we use brentuximab vedotin perhaps in the future, there'd be no need for that. So in conclusion, I can tell you that the event-free survival was similar between the treatment arms. However, more progressions and relapses were observed with ABVD, while early discontinuations were more frequent with BEACOPP. And in this high-risk group, conventional dose escalation with BEACOPP, the 4+4, provides better progression-free survival compared to ABVD, yet not good enough to improve the overall survival because of the toxicity. So additional considerations, treatment burden and cost, fertility issues, risk of relapse, risk of salvage, immediate and late morbidities may guide patient decisions toward ABVD or BEACOPP, which currently may share the claim of current standard therapy. From my point of view, is I'd rather give ABVD and not overtreat the vast majority of these patients who are going to do well with ABVD alone, particularly if their PET scan after 1 cycle was negative. So the bottom line is that 3 cycles of ABD without involved field radiotherapy has an excellent outcome for favorable stage 1A and 2A patients who are at the conclusion of treatment, who are fine at the conclusion of treatment. Disease control may be slightly better from combined modality as compared with chemotherapy alone, from 3 to 7%. Although a survival difference is unlikely, and the long-term effects we don't know of involved field radiotherapy. And I might deduce that if you did those PET scans, you wouldn't lose that 3 to 7%. In retrospective analysis, survival of Hodgkin's patients relapse after autologous transplant is superior by using brentuximab vedotin compared to those that did not get it. And we need to check this out more fully in a randomized study. And if you combine brentuximab vedotin with AVD, the results that you get, particularly in those patients who get a negative PET scan after 2 cycles, is as good as anything you might possibly want. And again, we need to do randomized studies. Bottom line, a general survey of studies comparing BEACOPP to ABVD, not the ones that I reported, almost all consistently show a superior progression-free survival for BEACOPP, but long-term survival seems to be comparable due to the toxicity of the BEACOPP. And as with limited stage disease, can interim PET scans be used to select out those patients not needing more aggressive therapy and thereby avoid all the unnecessary toxicity of BEACOPP? Now, Dr. DIEHL contends that it's genetic instability that means that you must start the ABVD right off the bat. But I'm saying to you is I can't believe that genetic instability plays a role after just one cycle if you did a PET scan. So I would advocate doing PET scans after one cycle. If those patients with disseminated disease look like they're doing well, stick with the ABVD. The problem is if that PET scan that's positive and on the second cycle proves to be positive as well, can you rescue that patient? Does that patient have inherent chemo resistance, and no matter what you do, you're not going to make them better? Perhaps maybe brentuximab vedotin will change what I'm saying. I just want to acknowledge the people in our lymphoma division of our Center for Lymphoma and Myeloma, and I thank you for your attention.